but due to Digno, still we are
Yes.
in unit. Today, should I start now?
Yes, please.
Okay. Today, the topic of my presentation is the selection of suitable recipient and the appropriate preparative regime. First of all, we will tell about the bone marrow transplantation. What is the bone marrow transplantation? The substitution of the blood forming cell and immune system. And on the other hand, it's also called the hematopoietic stem cell transplantation. Because nowadays on the worldwide the cord blood is also using for the transplantation. So it's also called the HSCT. And the hematopoiesis, the main precursor cells of the hematopoietic cells, which arises from the myeloid and the lymphoid. And myeloid divided into further three cells, that is the megacrite, granulocyte, and the erythroid. While the lymphoid divided into two cells, that is the B cell and T cells. And the every patient when comes to unit, and every family brings their feelings, their unique experiences, their concern, their worries, and about their kids. So the first session about their counseling. Counseling is very, very important. And after that, it's not only it's not only in the one session. Counseling session maybe takes many, many more session for their counseling of the patient and their families. And after that, for HLA typing, we take consent. Consent is a very critical component to establish the trust relationship between the family and BMT team. That's why, first of all, for the HLA typing, take consent. And after that, the first we evaluate the patient. Then for downstaging and preconditioning evaluation, then conditioning regime, and then we went to BMT. Why we evaluate the patient? Evaluation of the patient and risk assessment is done to establish on the four fundamental aspects. The HSCT indication, either the patient having indication of the for hematopoietic stem cell transplantation is present or not. To assess the patient for the transplant eligibility and counseling for the treatment option, and to choose the best donor, conditioning and post HSCT immunosuppressant, and to evaluate the result of transplant in large series. And indications of the HSCT, there are two types of the HSCT. That is the hematological malignant disorder and non-hematological malignant disorder. That hematological malignant disorder are acute meningeal leukemia, acute lymphoid leukemia, chronic meningeal leukemia, non-Hodgkin lymphoma. And non-malignant hematological disorder are the sickle cell anemia, severe aplastic anemia, Fanconi anemia, thalassemia, diamond black fan anemia, some metabolic disorder, and severe congenital immunodeficiencies. And what to look for the first visit? What we do on the first visit is we take the present history of the patient, past history, family history, medical history, and the general physical examination with weight and height. And the general physical examination, we palpate their liver and spleen size. Then lab investigation. Review of the diagnostic test in refer patients. Some patients refer from other hospitals and they have already some tests, blood tests. We review them. Then the confirmatory HLA typing. Although they have a HLA typing, but we do all this the confirmatory test for HLA locally too. And preliminary information on the therapeutic option and the result, HSCT procedure and possible complication and the side effects of the transplant. Then the laboratory test. And investigation after the HLA matching, what we are doing, we see the complete blood count, creatinine, total bilirubin, and basic coagulation profile, PTA, PPT, blood group, and antibody titers in the case of the ABO incompatibility. And then the serology and TPHA, malaria, tuberculosis by history, and the chest X-ray, and abdominal sonography, stool examination for ova and parasites, and urine analysis. And dental evaluation, we are also consult for the patient. And nowadays, as these are the COVID days, so we are doing also for the COVID test. Then there are the numbers of variables that have the prognostic value in the predictive models. And overall assessment, risk assessment. So there are the variables high and high risk. Age, that is depend on the age, general condition, and diseases, type of donor, HLA compatibility, and the CMV serology. That depends on all these the risk assessment. And donor, if the donor having age more than 35 to 40 years for male recipient, and female donor, especially if the multipairs. And the interval diagnosis HSCT prolonged, relevant in the CMLE and the severe aplastic anemia. Then iron overload, that is also a high risk, and the experience of center. Mean some center also having not a good, their result. So it's also depend on the risk assessment also. Then the risk assessment of the thalassemia patient, that is the Pesaro classification, and that is on the class 1, class 2, and class 3. If the hepatomegaly and the Z-score 3, that is class 1, and the liver fibrosis is not present, that is also in the class 1, and IV chelation on if the regularly, and they are include in the class 1. And if on the other hand, the hepatosplenomegaly present may or not, that is in the class 2, and the liver size on the Z-score, that is in the either it's present or not, that is in class 2, and regular or irregular IV chelation, that includes in the class 2. And class 3, that is the if the hepatosplenomegaly is present, liver size is more than Z score 3, and the IV chelation irregularly, it will be included in the high risk. And variable that is the alternative of the variable, that is the liver size. If the less than 2 centimeter, it will be in the low risk, and more than 2 centimeter, it will be in the high risk. Spleen non-palpable, it will be in the low risk, while more than 2, it will be in the high risk. And age less than 17, it is in the low risk, while more than 17 years old, it will be in high risk. Then the downstaging of the patient in case of thalassemia. Usually we use the hydroxyurea to downstaging, and having the large liver more than 2 centimeter below the Coster margin or 3 Z-score on the sonography. Using the hydroxyurea and any palpable spleen Z-score more than 2, and serum ferritin more than 2000 nanogram per millimeter, it will be more needed hydroxyurea. And diagnosis over 1 year of the age. 1 year of the age mean below the 1 year of the age usually diagnosed thalassemia, but more than 1 year, it means they have a good response about the hydroxyurea, and they are called the intermediate. And risk assessment for malignancy and other diseases, they are the multiple risk assessment score that predict overall the survival rate. And EBMT risk score score permits to predict the approximately 5 years probability of the overall survival and the transplant related mortality for the main diseases. This is the EBMT risk score, which having the variables, and it depends on the age, disease status, and interval of the diagnosis, and gender, and it will be gender mismatch or donor and recipient. If the values of the variable, and they have categorized in the points. If the less than 20 years of age, they categorize it in 0.0, and age 20 to 40, it is included in the 0.1, and more than 40 years, they have given the 0.2. So diseases of the status, if it diagnosed in the early stage, they gave the 0, and intermediate given 1, and advanced given 0.2. Like this interval diagnosis, the less than 12 months, the given 0.0, and less or more than 12 months, it given in the 1, and HLA identical sibling given given the 0. And the gender and donor recipient female to male given 0.1, while the other combination given 0. And risk assessment, the malignancy in the other disease, EBMT score, low risks given 0 point, intermediate 1 to 2 points, and high risk 3 or more points. And this the probability of the transplant related mortality at the age of 5 years, applying the EBMT this risk score. For example, this severe aplastic anemia at the age of 18 and having a 0, it increased the probability of the 18. And having 0.1 mortality rate is 26%, having 2 mortality rate is 40, and having a 0.3 it 49%, and at having a 0.4 transplant related mortality rate is 52%. And risk of the transplant is affected by according to disease, stage of disease, and the presence of comorbid conditions. And unfortunately, all these models have a relatively low predictive capacity, and none of them stand out more than the rest. Then therapeutic options. What are the therapeutic options? And conditioning therapy in the stem cell transplant. Centrally is the preparation of conditioning of the patient for the transplant. The three main goal of the conditioning therapy are the eradication of the disease, creation of space in the bone marrow for donor stem cell to engraft, immunosuppression to decrease the risk of rejection of the donor cell by the host cell. And then types of the preparatory regime. Myeloablative, non-myeloablative, and the reduced intensity regime. Myeloablative pre-transplant conditioning regime destroy bone marrow cells by using high dose radiation or systemic therapy. Number two, it is used to eliminate the recipient immune system to leave space in bone marrow for donated cell. Myeloablative regime is mostly used for the recipient with non-malignant diseases who require hematopoietic stem cell transplantation for marrow reconstitution or to produce complete donor chimerism. While non-myeloablative reduced intensity conditioning, non-myeloablative stem cell transplant and reduced intensity conditioning preparative regime uses lower doses of the radiation, lower doses of the systemic therapy, and used to reduce the organ's toxicity and transplant-related mortality. Possibility of the hematopoietic stem cell transplantation in elderly and in the patient not eligible for the standard myeloablative condition regime. It prevents the graft rejection, suppresses the recipient hematopoietic immune system, but does not eliminate it completely. In our centers for the cure to children, we are using the four this protocols MRDBST 5.1, 05.1 and 5.2. These both protocols we are using for thalassemia patient, while the difference is little the ATG that in the 05.1 that is used the in the low risk, and we are using ATG 4 mg per kg, and that is the genzyme, while and ATG and then fludarabine, ATG, busulfan, cyclophosphamide, cyclosporine, and methotrexate and flonic acid. The difference being 05.1 and 2 is the while this in this case the it is in using in the high risk or having a Z score of more than 3, and that it is used ATG used 5.5 mg per kg total dose, and the remaining like fludarabine, busulfan, and cyclophosphamide are the same. While this MRDBM, and SCG 06.1 that is used for haplo, and in this case we are using fluidex cycle 5 days fluidexel from day minus 68 to day minus 64, and then from day minus 40 to day minus 36, mean 5 day cycles, fluidex cycles, and fludarabine and we are using this, and then on day minus 12 to day minus 10, ATG and fludarabine, then busulfan, and in addition, we are using thiotepa for this haplo patients and rituximab. While the this protocol of using cyclophosphamide is little different, while cyclophosphamide we are using on day minus 2 to day minus 1, while and then plus 3 post BMT day plus 3 and day plus 4, 50 mg per kg per day. And this protocol we are using for severe aplastic anemia. In this case, we are using the ATG genzyme 4 mg per kg day minus 12 to day minus 10, and then fludarabine, cyclophosphamide, and the same cyclosporine and methotrexate. And these are the references that we are using these protocols, and this the all my presentation about our center, and some of them I have made from the EBMT. So if anyone have any question, kindly please ask. Thank you.
Thank you very much, Azra.
Thank you, sir.
Thank you. I know this was not very simple presentation. Also, I know you're going through a difficult time with the patient that did not do very well, and you were all close to him. So anyway, yeah, I thought this was a difficult. So I think